Councillor for Charlotte Central Ward in Oldham.
Thank you very much.
My name's Councillor John Wright, Councillor for Stockport.
Nice to see you again, Mary.
Councillor Mary Whitby, Councillor for Bury Metropolitan Borough. My first meeting, so nice to meet you all.
Oh, and Happy New Year, everybody. Patricia.
Oh, yeah.
Hi, I'm Councillor Pat Dale, Rochdale Councillor, Assistant Portfolio Holder for Healthy Lives.
Thank you. Claire.
Hi everyone. I'm Claire Parker. I'm the Director of Nursing, Healthcare Professionals and Quality Governance, and also the Deputy Chief Executive for Pennine Care.
Gosh, you've got quite a title, haven't you?
I know.
Andrea.
Morning everyone, I'm Andrea Osborne and I'm the Deputy Director of Finance at Pennine Care.
Thank you. Sam?
Hello, Councillor Sam Alhamdani. I'm Councillor in Oldham, substituting in for Councillor Louis Hamlet.
Oh, very, very welcome, and I'm glad a substitute's arrived. That's always most helpful. So we will begin with apologies, please, Peter.
Right, but apologies from Councillors Holloway, Gunter, Surgeon, I don't know, I presume that's how you pronounce the name, Councillor Susan Smith, and is it? Yeah, right, and Councillor Hamlet.
That's a lot of apologies, but never mind, we're here, aren't we? So next item is declarations of interest. Has anybody got an interest to declare? No? Moving on to the minutes of the last meeting, which was the 22nd of September. So we obviously missed the November one, did we?
Yes, there wasn't one in November, Chair, yeah.
No, okay.
Yeah.
So I presume you've all read the minutes. Has anybody got any problems with them? Any items they don't agree with, or something that's been missed out?
Move that the minutes be taken as a correct record, Chair.
Thank you very much.
There is one, just before you move on from that, there is one issue that's outstanding relating to a meeting that was to be arranged for Councillor Smith and Councillor McLaren to meet with the Chief Executive of the Trust, which I'll endeavour to organise as soon as.
Yes, it's all been very difficult, hasn't it? Yeah, so there's just that one issue that's been acted upon, is that right? So it's been proposed. Does somebody want to second it?
Yeah.
Please.
I'll second Pat.
Thank you, Patricia. I'll call you Patricia, it makes a difference, doesn't it? Or you can call me Patricia, I don't mind. But we need to have something between us. Any urgent items of business, Peter?
No, Chair, no.
Right, so we can go straight on to you, Andrea. Financial update. We'll be having a cup of tea out in a chair shortly, won't we? Carry on.
Thank you. Yeah, so a very different year from a finance perspective, not just Pennine Care, but for all organisations, obviously, in response to the pandemic. So we're discussing actually what we're looking at the moment is the financial year. It's been described as a year of two halves. So for the first 6 months of the year, well, for all of the year, actually, we're still under a very, a national command and control regime. So for the first 6 months of the year, all providers were supported to deliver a break-even position. So we were all given, I guess, monies to ensure that our income was aligned with our expenditure. There was no national requirement for efficiency savings. What we did do, though, what Pennine Care did continue to do, is to push ahead with our corporate redesign programme. As you'll be aware, we transferred community services back in 1920, and obviously we, as a result of that transfer, that was with costs in our corporate services that weren't able to transfer to the receiving organisation. So it's important that we right-size our functions now and reduce our cost base in our corporate services. So we've continued to push ahead with that, and we have managed to release some efficiency savings over the entire year of just under £1 million this year. So and I think that is a real achievement given the pandemic. A lot of corporate services staff were redeployed to support frontline clinical services during the pandemic. So it is a real achievement. Probably just worth noting that in response to the COVID-19 pandemic, we have been tracking our costs, and we spent about an additional £3 million on staffing, consumables and equipment. So all trusts have been asked to report that nationally, so we can understand nationally what the costs of the pandemic have been, and that's what we spent in the first 6 months of the year. Going forward then, from October onwards to the end of March, we're still very much under this national command and control regime, but the system has moved, it's moved on with its financial framework. And what we're operating now is, rather than it being a provider that's delivering a financial position, it's more around the entire Greater Manchester system has to deliver an overall financial position. So all organisations were asked to step up efficiency programmes for the second half of the year, and we were asked to deliver a minimum target of about 1.1% the second half of the year. That's what all providers have been asked to do, and obviously because of our corporate redesign and we're forging ahead with that, we are on track to deliver that target. So at the moment, the Greater Manchester system is all financial positions within the Greater Manchester system have been agreed, and we are on track to deliver the system envelope that we've been given. It is very challenging for all organisations, but at this moment in time, we are on track to deliver that system position. I guess just within that, in terms of the income that we've received, nationally, there's been continued focus on delivery of the mental health investment standard. So that's where all commissioners are mandated, if you like, to invest in mental health over and above their baseline funding. So each year, commissioners receive an uplift to their allocations for growth, and they have to declare that they're spending a proportion, the equivalent proportion of their growth monies, that's their parity of esteem money, plus an extra 1.7% on mental health. So we have secured that funding into our services. That was about £6 million into our direct clinical services in 2021. It's around areas such as investment into our community mental health teams. There's some investment into our home treatment teams, and we are pushing ahead with recruitment to staff into those areas. So that's really positive news in terms of ensuring that we continue to receive that investment to stabilise and bolster our services. We've continued to invest our capital in line with our original plan, and you'll see that we have continued to invest in the rollout of our electronic patient record. We're continuing with the eradication of dormitories programme that I believe you're familiar with from previous meetings, and we have well, I'm assuming that you've been made aware, but we have received the funding now from the Department of Health to push ahead with building our Tameside female PICU. That's really positive news. Just before I move on to the next slide and start talking about next year, are there any questions on this year?
I'll start with one. Thank you for that, Andrea. It's very clear. You say for the mental health, you're increasing staffing. I think it's community mental health. How's that going? Because I know it is very difficult to recruit experienced or trained staff. How are you dealing? How's it going? How's it moving forward?
Claire, do you want me to take that, or would it be better to hand over to you? I think you might be closer.
Oh, I asked the wrong person. Sorry, but you brought
no, it's all right. It's okay.
That's all right. I think it'd be fair to say it's an ongoing challenge for us. And I think when I go on to talk about where we are as a trust in terms of responding to COVID, I think some of our challenges have definitely been some of the staffing availability. Obviously, as a result of COVID, there's been increased sickness of our staff, as well as trying to recruit people during a pandemic has its own challenges in itself. I think what we would say is, we've got all efforts. We continue with our efforts to continue to recruit people. We're looking at the recruitment process right the way through from nursing associates, nurses being supported to go through the training. We continue to support nursing students in our different services, in the wards and in community services throughout the pandemic. And because the changes to the nursing and midwifery standards and also the deanery through the medical students, we were able to support those placements throughout the pandemic. But again, that's still a challenge for us to then recruit people into the posts and for them to stay with us as kind of permanent members of staff. So it's an ongoing issue. So we do work collectively across the Greater Manchester patch with our colleagues as well to try and attract people to come and work in the Greater Manchester footprint, and particularly for us in Pennine Care. So it is a challenge, but we do continue to have a lot of effort in trying to attract people to come and work for us.
Thank you very much, Claire. Any other questions? Yes, Councillor. I've forgotten your name isn't on, so I'm sorry I haven't got your name. It's just.
My name's Colin McLaren, Councillor for Cheltenham Central Ward.
Colin.
That's who you're looking at. Yeah.
Thank you very much, Colin.
Right. Yeah, the questions on a similar theme, actually, Chair. Maybe one for Claire to answer. But you talked about your staffing situation. What we could do with a little bit more on is how many agency staff you still might be employing. How many were redeployed? Were there any redundancies as a result of this exercise?
To my knowledge, I don't think we've had any redundancies. Andrea, can you? Yeah, we've not had any redundancies. The question about how much agency staff have we used, we can probably pull that information together for you. Obviously, we continue to. We've got our own bank in Pennine Care, so we have our own staff who work through what we call a bank, which is our internal way of providing temporary staffing. So we have obviously used increased number of staff on the bank, but obviously agency as well as a result of the pandemic to support our workforce across the entirety of our services. What I would say is during the first wave of the pandemic, we did redeploy quite a lot of our staff that sit in corporate services in terms of supporting delivery of things like the personal protective equipment, delivering things across services, providing additional support where it was needed at the time. And I think as we are currently in the kind of next wave of the pandemic, we are continuing to look at where staff need to be redeployed so that staff are utilised in our patient-facing services as much as possible to ensure that we're able to maintain that. So obviously some of our other services have either slowed down or we've not been able to progress with some of the work that we were originally doing because those staff have been redeployed. But we can certainly get you the data on bank and agency.
So thank you for that, Claire. Just as a supplementary, Chair, were any staff redeployed to other trusts or to other health organisations rather than redeployed within, as it were, within the organisation, as it were?
As far as I know, no, we didn't have any staff redeployed. I know that some of the acute trusts may well have redeployed staff to perhaps the Nightingale Hospital in Manchester, but from a Pennine Care perspective, we didn't at the moment. We haven't. That's not to say that we might not need to do in the future.
Are you all right with that, Colin? Yes, he is.
Well, obviously, as Claire suggested, she's going to pull some figures together, which I would hope she would be able to share with the committee, rather than just me, that if they come through Peter, then he can arrange to circulate them to all.
Yes, they must go. Yeah, I hope she will send them to all. I'm interested in the increased cost of agency staff, which might be a point of your question. So if we could have that in as well, please, Claire. Right,
yeah,
John, your hand up. Yeah, John?
Thank you, Chair. Maybe I should have asked this under about the minutes. I was just interested in how the transformation to single-sex accommodation across the trust was going.
It's on the report, actually. You know, Andrea sent out a report.
I can talk. I can talk to that later. I've got a couple of slides later. I don't know if you want us to share the slideshow on the screen.
If you could, yes,
I was
please.
wondering about Andrea, but I assumed that you'd all rather run it off because the report came in.
I'll see if I can do it.
You should be able to. It's enabled for people to.
Sorry. So that's again, Peter.
It is. It should be able to share the. Be able to see this.
Can you see that?
Yeah. Yeah. That's fine. So, John, Where are you? Are you at the bottom? Do you want to do your question?
No, I'll wait till it comes up in the.
You wait till it comes up. Okay. Has anybody else got a question? I can only see some of you, I'm afraid, with the screen. Okay, Andrew, do you want to carry on?
If you could move to the next slide, Claire, please.
Chair, sorry, I think Councillor Dale wants to.
Yes, I can't see everybody with the split screen. Thank you. Okay, Pat, do you want to go forward?
Thanks, Pat. It might be on the next slide. Just on page 4 of the report, Andrea, it states that there's an early indication that there are significant financial pressures for the GM system. Now, we know about the staffing, obviously that's a huge pressure. I was just wondering if you could give us some detail about the other pressures which are obviously, you know, causing concerns across the system. Thanks, Andrea.
Yeah, no problem. Are you referring to the slide that Claire's now on and the bullet point around capital funding?
No, I think it might be. It's on page 4.
It is that one.
It is that one, is it?
Yeah.
Right.
Right. Okay. So in terms of, I'll see whether I answer your question. If I've not, please do ask me to clarify. In terms of the forward look, then thinking about the next financial year from April onwards, it's probably fair to say it's a bit blurry at the moment, to be quite honest. We were expecting planning guidance to come out later this month, but we've been given an indication that actually, because of obviously the challenges now that all organisations are facing, that there's been a delay to both the planning and the contracting process. And what the expectation is that the current financial framework will roll over into 21-22, and that's probably until at least the end of Q1. So probably until the 30th of June, we will continue to be under this current financial framework, this sort of command and control framework, where, if you like, whereby we are told the income that we are receiving, we will be given some money to deliver a financial position across a GM system. And then within that, providers will have to probably have to continue in delivering a level of efficiency savings. So the expectation is what we've experienced in months 7 to 12 will probably just continue into the sort of first quarter at least. What we don't know is what it looks beyond that. We don't know that at the moment. So we don't really have a complete understanding of what our financial position will look like going into the following year. I guess what we do know is that obviously we still have quite a significant financial gap at the moment. So we still need to be thinking about our transformation programs, and we still need to be forging ahead with our corporate redesign to try and make sure, irrespective of the financial gap, I guess, to try and make sure that we, that all of the money that we spend, that we obtain value for money, if you like, and can redirect as much of our resources to frontline services as possible. We do know that there'll be national funding available for mental health again next year. There's quite amounts of national funding being made available for both community and for crisis services, but there will be an expectation that for us to be able to access that money, that commissioners have invested the right levels from their own allocations. We're looking at that at the moment, but that might be a challenge for some localities where historically we haven't really invested fully to achieve the levels, both in our community services, where we know we've still got gaps in terms of our baseline community services offer, and our crisis services, where we know that we've still got gaps in terms of meeting our compliance target, if you like, the national compliance target for some of our crisis services. So we're working with Greater Manchester to try and understand how we can mitigate that, if you like, and how we can alleviate some of that in order to be able to access some of this national funding, because it's quite significant amounts of national funding that are being made available. In terms of capital, we know that there will be a total envelope made available across the whole of the GM system. So what's happening at the moment is all providers are being asked to put forward what their capital plans are for next year. And we are being asked to prioritise those capital plans, so we can say how much of our spend is contractually committed, how much of our spend is because we've had to, so we're carrying things over from one year to next, so schemes that are being carried over from one year to next, such as the female PICU scheme, for example, the rollout of our electronic patient record. Those are multi-year schemes. So we're being asked to prioritise all of our capital programme, all providers have been asked to do this, into what's contractually committed, things like what's high risk, significant sort of backlog maintenance kind of works, etc., etc. So there's a whole prioritisation framework that's going through the GM system at the moment, and what we'll have to, what we'll have to agree as a GM system is how collectively do we spend the capital monies that are available to us to be able to live within that capital envelope. Does that make sense for the question that was asked earlier?
That's great, Andrea. That makes it much clearer. Thank you for that.
Yeah. So it's very much, and I think this will continue. I think some of the messaging that's coming out of the centre, I don't think this sort of framework will necessarily go away. I think as we move forward with the the development of integrated care systems, etc., we will be very much working at a system level, and the finances we will be held to account for the delivery of our own financial position and for for spending on our own capital programme, but that will be in the context of delivering an overall system position across Greater Manchester.
Thank you.
Okay, has anybody else got a question? No. Right, Andrea, are you continuing?
Sorry, Chair, Councillor McLaren wants to speak, I think.
Okay.
Okay, thank you, Chair. Andrea, just what I'm finding slightly disconcerting, as it were, given the sort of degree of uncertainty that appears to be surrounding the budget, and given the fact that we need to set a budget before the end of March, as it were, to what extent are you in a position to do that at this point in time?
Yes, so we are internally, I guess we are still pushing ahead with our own operational management budget process. So we're still continuing as normal. I guess the bit that we don't know. So for example, what we would normally get at this time of year, we would normally be given an indication of what a pay award, what the pay award uplift might be for next year, and some of those economic inflation assumptions. So we haven't got those as yet. But we are continuing with our own operational budget setting process. We are continuing to work with our commissioners to say, if we weren't in that command and control regime, what do we think our contract income would look like? I guess the bit that we're not cited on is, in terms of, you'll be aware that historically what we've had is to allow our income and expenditure to balance, we've been given, if you like, a top up, a pot of money from the centre that allows our income and expenditure to balance. What we don't know at the minute is what that top up will be, and therefore once we've said this is what we think our income is, this is what we think our expenditure is, therefore this would be, in any other year, this would be our financial gap. What we don't know at the minute is how much money will we be entitled to bridge that financial gap, and therefore how much would we have to deliver of efficiency savings. So we sort of, I guess, we're running parallel almost, if that makes sense. We're trying to forge ahead internally, but without that sort of, national planning guidance that would give us some of those, some of that.
Well, does that mean then, Andrea, you're going to have to set a sort of worst case scenario budget at this point in time? I mean, is that something that you're going to have to contemplate? And is there any likelihood that there might be any funding to cover the 3 million that you'd said you've spent on additional spending on COVID-19, etc.?
Yeah.
Is there any possibility of that being offset by central government, do you think?
Absolutely. I think the COVID spend, yes. So we've been audited on our processes for COVID spend, and that's been given sort of a level of assurance. So we're happy that the way that we are reporting our COVID spend is accurate. All COVID spend is being covered from a national perspective, definitely in months, in the current financial year. So I'm not hearing anything at the moment that would suggest that sort of framework would change. So we do anticipate that our COVID spend would continue to be covered, which is why we isolate it separately. In terms of worst case planning, I think obviously that will be a board decision, to be quite honest. What we will be doing internally is presenting our board with our operational planning process, and then I would hope that by then there's more guidance from the national team, probably around February, March time, but we will be presenting our board with the outcome of our operational planning process, and it will be for board to then decide. You know, I guess when you say worst case, it's how realistic it is as well. So we know that we've got real challenges on taking efficiency savings out of our services, not least because we know that there is an historical underlying deficit in the amount of money that's being invested into mental health. So to a certain extent, it's not really worst case scenario. It's about credible financial planning and being clear on actually what is within our gift to deliver.
I think the other thing that, oh sorry, I was just going to say, I think the other thing that I would add to that is, I think Andrea will probably reflect as well, it is a changing landscape all the time. So I think each month different things come into play that we need to take into account. So as I'll go on and talk about shortly, you know, at the moment, we are rolling out the vaccination, and that's something that I think, you know, a few months ago we weren't, we knew it was on the horizon, but I think in terms of timescales, it's very difficult for us month on month to be planning with any degree of, I guess, assurance that that's where we're going to be in the next month or two, because it is changing so rapidly and so dynamically, really. So I guess we are working with very, very much a changing landscape all the time, not just financially, but with delivering our services.
Yeah. So is the budget process something that could be shared with us? Do you think, Andrea? It's at some point.
Yes, Andrea. Yeah.
Yeah. No. Yeah. We have a. It's our standard operational planning methodology. So yes, I can dig that out and share that with you, Chair.
Probably at the next meeting. If hope we have one anyway. All right. Has anybody, I can't see the other screen. Let me have a look. Has anybody else got a question? Are you all right? All right. Thank you. Can we move on then with either Andrea or Claire? I'm not sure who's speaking.
Yeah. It's me next. So we'll just move on to the.
Just to interrupt, I did give my apologies. I'm sorry, I need to leave now. So
no, that's fine, Andrea. Thank you very much.
Questions after? That's fine. Thank you.
I'll pick it up with you. Thanks, Andrea.
Thank you. Thanks.
I think Claire can probably sort out all the questions. We'll make sure she does.
Oh, hopefully. Hopefully.
Thank you, Andrea.
Bye, Andrea.
Bye.
So I'd just go on to a bit of a COVID-19 update as to where we're up to, and I just want to start really by paying tribute to the number of staff that we've had that have worked incredibly hard during the COVID pandemic. We can't underestimate the impact that it's had, and I think from our perspective, we've seen staff going above and beyond. They've really been committed to providing safe, high quality care for our patients. Obviously, they are working with the fact that it's impacting on their families as well, that is outside of work, and obviously as a trust we've been trying to support their health and well-being as well. So it has been a challenging time, and I think it continues to be a challenging time. So all credit to the staff and everyone involved in providing services to Pennine Care. It has been incredible, really. So I just wanted to reflect at the moment where we are. So we do have an increased impact both nationally and regionally. I've got an update up to the 19th of January. So we have had a number of wards that were closed a couple of days ago, one in Tameside and one in Stockport. Because of the number of COVID positive patients or the acuity of our patients on those wards. The infection rates across Greater Manchester, as you'll have seen on the news, have been fairly fluctuating, but obviously increasing. And obviously there is, as a mental health and learning disability trust, we have the impact of where we are in terms of the acute hospitals are obviously under additional pressure, and that does have a knock-on effect on the system across Greater Manchester that we need to be aware of. As of Monday, the 18th of January, we did have 36 staff who were tested positive for COVID, but that's reduced since the previous week. We obviously have staff that end up having to isolate as a result of test and trace, and we've had 2 recently. We've got 38 staff who are shielding and 20 staff who are shielding related to COVID. We've got a number of staff who have got challenges in relation to childcare. Obviously, the impact of the schools and education changes does have an impact. And obviously, we do have some staff that have, homeschooling, and some of our staff are working at home. Some of our staff are obviously on the frontline services. We do have staff that unfortunately are on bereavement leave, and we have got 5.8 staff currently off sick, and of those, it's 0.9% of staff that it's due to COVID. We've got a number of confirmed inpatient patients that have got COVID positive, and that's 18, but we don't have any patients that are on oxygen at the moment. And sadly, we've had 1 inpatient death that's been reported in the last 4 weeks. That was a patient who was on one of our inpatient units that transferred to the acute. In terms of personal protective equipment, our current stock levels are fine. We do keep a track of where we're up to. We have started, just before Christmas, we started doing the lateral flow testing for our staff. And we get our staff to do testing twice a week, and then that if they get a positive test at home with the lateral flow testing, they then need to go and have a PCR test, which is the test that will determine it's slightly more accurate than the one at home. So if they get a negative PCR test, then they're okay to come into work. But if they get a positive PCR test, they have to isolate in line with the guidance. But in one sense, it gives us a flavour of understanding kind of how our staff are testing and their ability to come into work as a result of testing them for COVID on a regular basis. One of the successes that I think we've had is our flu vaccination rate. We have vaccinated 79% of our staff this year, which is a massive increase. Last year it was 45%, so we've had a real push on the flu vaccination. And the reason that that's important is obviously flu is important for us to vaccinate our staff, but in order for people to have the COVID vaccine, they needed to have the flu vaccination at least 7 days in advance of the COVID vaccine. So we had a real push before Christmas on getting as many of our staff as possible vaccinated against the flu. We are delighted that we launched our vaccination hub on Monday. So we've got the vaccination hub, which is at our trust headquarters, and we will be vaccinating 200 people a day. And in addition to that, our staff have been accessing the vaccination hubs at the acute hospitals, so at Stepping Hill, at Tameside, and in the hospitals in the Northern Care Alliance. They've been supporting accessing our staff to the vaccine, which is great. So as it stands at the moment, we've got 8 a.m. till 8 p.m, 7 days a week. The vaccination hub is running at trust headquarters, and we're going to vaccinate staff as quickly as possible. And then obviously we are also working on vaccinating our patients over the coming weeks. I think, as I said, there's an incredible amount of effort into managing the COVID update. We are doing a lot of work on our staff well-being to support them through this period. And then just the final point, really, obviously we engage regularly with CQC, and we are continuing with the work that we want to do in order to meet our improvement plan that we've had in place. And I'll go on to talk about the single gender accommodation update shortly. But just to note that CQC have obviously had to amend and change their inspection regime as a result of COVID. We still have the Mental Health Act assessments. Those are done virtually, where the CQC Mental Health Act inspectors will contact the ward, they'll contact the patients, they'll contact the advocacy services and patients and their families to do those assessments. And those have still been going on remotely. We haven't had any formal inspections by CQC, but nationally, what they are doing is if they've got any concerns about a provider, excuse me, they will come in and do a very focused inspection. We haven't had any focused inspections since the start of the pandemic with CQC, but what we do have is regular engagement meetings on a quarterly basis, and we have a regular dialogue with CQC just to pick up any issues that we might want to let them know about. But obviously, CQC are still playing a role in regulating us as an organisation. So that was it on the COVID update as to where we're up to.
Okay, can I just stop you there in case there's some questions on the COVID update? I've just got one. I was interested in the lateral flow test and then having the other test if it was positive to see if it was correct. I'm interested to know how that's panning out. Is there a great difference? Do they find that when they get there, they're negative, and the percentage of difference?
I think
it isn't the lateral flow test.
Sorry, I didn't catch that last bit.
It's not considered terribly accurate, the lateral flow test.
So I think the lateral flow test is less accurate than the PCR, but it does give an element of accuracy. I think it's definitely over 50% that it's accurate. So once the member of staff has done the lateral flow, if it's positive, then the reason for the PCR is to determine whether that positive is a definite positive. PCR is more reliable than the lateral flow. I couldn't tell you the conversion rates at the moment, but the number of staff that we've had testing positive will then have to isolate, so that'll be reflected in the figures that I gave earlier about the number of staff that we've got who are isolated as a result of COVID.
Okay, thank you, Claire. Any more questions? Colin?
Yeah. Thank you, Chair. I think we'd all like to take this opportunity, Claire, to thank the staff for all their incredibly hard work over this past 9 months. And they've obviously been working exceptionally hard. And there doesn't appear to be any light at the end of the tunnel at this point in time, other than the vaccination programme, of course, which we hope will begin to bear fruit. But what I'm also interested in, the fact that you've had so many staff that have been unwell, self-isolating, etc., all sorts of different circumstances. To what extent might that have impacted on the Trust's ability to continue to deliver its programme over this period?
I think, it'd be fair to say there have been times when our business continuity plans have had to be brought into play. And I guess hence why we have had to at times redeploy staff. We've had staff that we have had to move into different priority areas to make sure that we have been able to continue to provide safe services for our patients, really. I won't deny it's not been a challenge, but I think with our ability to kind of move staff around, but also use the bank and agency as needed, it has enabled us to do that. And we've kept closely monitoring it. As Andrea said at the beginning, we're very much working in a command and control environment. So we've got what we call gold command calls. At the start of the pandemic, we were having gold command calls most days. We're now down to having gold command calls twice a week. So it enables us to have that oversight and monitoring of kind of if there are any hotspots in the organisation where we might need to redirect resources to enable us to manage. And again, as I say, it very much is day by day thing that we're doing, but because we're in gold command, we are able to keep a grip on that. And in addition to that, we're also contributing to the gold command across Greater Manchester, which obviously, as and when we're able to support. I know, as I mentioned earlier, there are times when we've needed to offer support. Our resilience hub has offered support to some of the staff in the acute hospitals, and some of our psychological therapies has been working, obviously staff who are working in areas like critical care. From a mental health and emotional health perspective, we have been able to support and offer mutual aid for our colleagues across Greater Manchester. So it is very much a system approach, really, but acknowledging that it is tough. But thank you for your positive comments.
Have you, just as have there been occasions when you've received Gold Command support from other trusts and so on across Greater Manchester?
Yeah, so there's been a number of different areas where it's things like personal protective equipment. I know that we've provided support for that. I mean, if you think about the vaccination, so it's only now that we've been able to implement the vaccination, but some of our staff have received mutual aid from our acute trust colleagues who've been implementing vaccinating their staff with the Pfizer vaccine. And because of the conditions that the Pfizer vaccine has to be kept in with the very cold temperatures, it's only the acute hospitals that are able to do that. So they've offered us the support in terms of vaccinating some of our staff, which has been fantastic. So yes, I think it's been a really good effort across the system, really.
Excellent, good collaboration. Any more, Colin?
No, that's it for now, Chair.
Yeah, Pat, Councillor Dale.
Thanks, Pat. The lateral flow testing, I mean, my big concern about this is that there are so many false negatives. I mean, the false positives, obviously they can be confirmed. You can't confirm a false negative, because what happens is staff think they're okay, they go back into work, and obviously the virus is then spread. But the question I was going to ask was about the 2 wards, Claire, that you said are currently closed. What happens to the patients in those wards?
Okay, so let me just... in terms of the lateral flow, one of the things that I would say is all of our staff, when they do come into work and in their work environment, have got sufficient personal protective equipment which will protect the virus spreading. So we are constantly sending out messages. We've got staff that are going out checking that people are using their personal protective equipment correctly. So they have masks that are worn all the time on our inpatient and clinical areas. When they're doing patient contact, they will have gloves and apron as appropriate. All of our staff that work in offices wear masks all the time, and that's following the Public Health England guidance around that. So I guess even if they have got a false negative on the lateral flow, they will still be taking the appropriate precautions when they are in work. So I guess we look at it as, in one sense, before we had the lateral flow, we were still doing those measures anyway. But now we've got a better picture of those that are testing positive through the lateral flow, and it is giving us more accuracy of that. But as you say, you know, those people who are asymptomatic, we're never going to get to the point at the moment with the testing that we've got available to have that 100% certainty. But we obviously make sure that they wear their personal protective equipment to make sure that they're as safe as possible, and the risk of transmitting the infection is significantly reduced. And in terms of the ward, if we've got patients that are positive on the ward, we try and cohort patients as much as possible. They are nursed in a way that will reduce the spread of infection. Once we've got a positive test, patients do isolate, so they've got their own rooms. So we've got different ways depending on, so when any patient comes into one of our wards anyway, as soon as they're admitted, they are tested, and they have to isolate until the result of that test is known. Once we get the result of that test, if they're negative, then that's fine. If they are positive, then they are isolated within the guidance that we're following from Infection Prevention and Public Health England, because obviously we have to treat each ward as the equivalent of a household. So as much as possible, we have to reduce the spread of infection in that ward environment, and we can do that by supporting our patients to isolate.
So Claire, when you say the wards are closed, you mean they're closed to new patients?
New admissions.
Yeah,
yes,
new admissions.
They're closed to new admissions. And obviously, throughout the pandemic, we have had to restrict things like visiting and leave arrangements. But again, those are done very carefully on a risk-based approach. And we have to align ourselves with the national guidance from the government. So, you know, we have to make sure that our visiting arrangements, at the moment, we don't have visiting on any of our wards other than our children's inpatient units and if we have any patients that are sadly at the end of life, we would support visiting, and that's in line with what's happening nationally. And we do recognise it is very tough for people not to be able to see their loved ones, but we do have to kind of take that wider approach at managing the infection. So,
thanks, Claire.
Thanks for that question, Pat. And I thought it meant closing the wards and patients hanging around in the corridors. I'm glad you clarified that. Okay, any more people asking questions? I keep looking at the other, but everybody's quiet there. Okay, do you want to move on now then, Claire, to your...
I will do.
Yeah.
So I think it was mentioned earlier just around our single gender accommodation update, and I'll try not to go over old ground because I know that we've presented at this committee before around where we were up to. So as a trust, we are moving towards single gender accommodation, but also to eradicate our dormitories that we've got in the organisation. We had a business case that went to our board at the beginning of last year, and over this year and over last year and this year, we are moving towards single gender, and obviously that's to promote patient safety and privacy and dignity for our patients. So I'm pleased to report that Stockport adult inpatients moved to single gender on Monday, the 4th of January. Bury adult inpatients are due to transition by the end of January, and that timescale's been increased. We did have a number of incidents that made us look at the timescales, so we've brought that timescale forward. But also because we've been successful in the way that we have implemented the single gender in other areas of the trust already, we felt that there was no reason why we should elongate the process any longer. So we are doing that. The transition to single gender and functional and organic split across older adult inpatients is on schedule. That started in mid-February, and that's happening across Hayward, Middleton and Rochdale, Bury and Oldham. One of the things that we've done is we've had to speak to staff as part of this process to ask if they would prefer to work with males or females, and also on functional or organic wards. Ultimately, the staff have actually preferenced, and it's worked out quite well for us, I think, in terms of where they've wanted to preference. So I don't think it's caused too much disruption to the staffing teams. The dormitory work on our Ramsbottom ward has concluded, so the now Ramsbottom ward has no dormitory beds and it's fully reopened. And further work is going to continue around improving the ward environment. One of the things that we want to do is improve our environments as much as possible to enhance the patient experience whilst they're on the ward. And then we've got planning for the move to single gender and functional and organic split across the South Division, which is Tameside and Stockport, in the next couple of weeks. So we are progressing at pace with the single gender accommodation update. It is working out very well. As a trust, we are taking part in the National Sexual Safety Collaborative. So obviously we are doing a lot of learning around that, which is great. So that was all I was going to say on the single gender.
Thank you. Just can I ask John if it's okay with that? Are any questions?
No, it was more the safety aspect that I was concerned about, and that seems to be answered.
Yeah, it's all there. Thank you very much, John.
Thank you.
Back to you, Claire.
Okay, so we have had a number of changes to our board of directors in the last 6 months, so we felt it might be useful and timely for us to give you a bit of an update. So obviously I think you've all met Claire Malloy before. We've got 2 new directors in the organisation. So we've got Nikki Tamanis, who's joined us. She joined us in September as our Executive Director of Finance, and Professor Nihal Fernando joined us August, September time, I think, as our new Medical Director. So we have had some new changes. And then since the retirement of Dr. Henry Ticehurst and Suzanne Robinson, who were the previous Deputy Chief Executives, myself and Keith are taking on that shared role as of August last year. In terms of our chair and our non-executive directors, there have been a number of our non-executive directors who've come to the end of their term. So we do have a number of new non-executive directors and some changes. So Daniel Benjamin has taken on the role of deputy chair. He's been with us for some time. And Mike Livingston has taken on the role as the senior independent director on the board. The new members that we've got Claudette Elliott, Maksud Ahmed, Liz Allen and Edward Vitalis. They are all new non-executive directors in the trust. And then we've also got Saeed Atcher, who is an associate non-executive director. So this is somebody who will be working within the trust to aspire to a non-executive director role in the future. So it's supporting him to be in a position to be able to apply for a non-executive director and giving him the experience of that. And then we've also got Nigel Gluden, who's part of the Insight programme, which is a programme that's run to support people, again, aspiring to move into non-executive director roles. So there's been quite a lot of changes in our board, really. So it was just to update you on some of those new members.
Okay, any questions on that? Is that it about the changes in the director's plan?
Yeah.
Okay, and is that you finished? Or
no, I've just got one final bit, if that's okay.
Councillor McLaren wants to speak, Chair.
Who?
Sorry to interrupt, Chair. Councillor McLaren, I think, has got his hand up.
Okay, Councillor McLaren, can you?
Yeah, just back to the changes and things, Claire. It has in the past. You might recall that at one stage the committee was working with the chair and non-exec directors on a joint programme, which I think has been disrupted by COVID-19, etc. I wonder if there might be any opportunity at some stage, when circumstances allow, to return to that programme.
Yeah, I'm sure there will be. I think Louise Bishop's on the call, so we can definitely look into restarting that as soon as we're able.
Okay, John, any more? No? All right, Claire.
Okay. So this is the final section, really. So it was just to inform members around our new integrated leadership structure. So we'd had a business case that went to our board last year around changing the structures in the organisation to increase the amount of clinical and professional leadership that we had in the trust, and to make sure that that clinical and professional voice is heard in the organisation. So I'm pleased to say that we have recruited to all of our new roles, and the original implementation was May last year. However, obviously we've had delays due to COVID. And the model that we are implementing at the moment is what's called a triumvirate model, which is very much integrated leadership. So it has, and we've created 3 networks. So we've got the South network, we've got the North network, and we've got the specialist network. And at the head of each of those networks is a network director of operations. And I think we have had a lot of operational management in the organisation already. But the difference is that we're now incorporating a network director of quality nursing and allied health professionals, and a network director of a network associate medical director. So we'll have medical, nursing, AHP leadership in that. And we've also got some heads of professions. So we've got heads of nursing and heads of AHPs, and also head of psychological therapists. So we've got lots of clinical and professional leaders taking some of those leadership roles to collectively support the management and lead the organisation in each of those networks. That's a new way of working for us. And we have also got an organisational development programme in place to support that. So it'll include things like coaching for those groups of leaders who will be working in a different way. But hopefully, and we know that this model is in place in a lot of organisations that are currently rated on a CQC basis, good and outstanding. And we know that it works in other areas in providing that integrated leadership approach. So we're optimistic that it will help us on our improvement journey in Pennine Care. So it is improving the capability and capacity in the leadership in each of the care hubs as well. So we've sitting underneath the network directors in the South, North and Specialist, we'll have each of the boroughs, and then we also have learning disabilities, our rehab and high support services, and also our children and adolescent mental health services. It's focusing on 6 key principles. It's collective leadership, it is devolved decision making, and looking at whole system leadership. And I think it'll also help to position Pennine Care in some of the integrating care work that's going on across Greater Manchester, and we'll definitely be in a good position for that. So what happened in 2020, we successfully recruited to all tier 1, 2 and 3 posts. We've got the organisational development programme that we've commissioned to support the implementation of this. We're developing some masterclasses to support new roles in terms of finance, freedom to speak up, performance and contracting. And it might be that some of them might want to come and observe the Joint Health Overview and Scrutiny Committee as part of that development, which I think would be really helpful. We are reviewing our governance structures and systems and processes. Some of the key changes we've got are around transitioning Healthy Minds to the borough care hubs. So previously, Healthy Minds was seen as one service across Pennine Care, but actually we think, in line with the community mental health framework that we are moving towards, that having Healthy Minds in each of the boroughs makes more sense in terms of the local care offer to patients and residents in those areas. Transition of psychological medicine, military veterans and the Manchester Resilience Hub will sit in our specialist services. And then across the trust, we've had quality leads and matrons. We are combining those roles and ensuring that we've got a broader spread of heads of quality across the organisation. So that's been quite a change for us. We are launching it on Monday, so there will be a communications plan. So you might get a copy of the structure, and certainly I'll get Louise to make sure that we send a copy of the new structure out to you so that can be distributed. And then for next year, obviously, we are continuing embedding and monitoring and evaluating this new model. Because it's a new way of working, we've got to let it to settle in the organisation. We're going to go through that process of transition. But what we want to do is, in about 12 months' time, just reevaluate if we've got it right, if there is areas that we want to develop further, and to continue with that. So I think it's a real positive move for Pennine Care to have increased the clinical and professional leadership in the organisation, and to make sure that we are offering that holistic approach to our patients, which ultimately, as we know from other organisations, is something that positively contributes to outcomes for patients. So, and that was it.
Thank you, Claire. Any questions from anybody? Oh, everybody's up. Oh, Mary, off you go.
What is the success criteria for this new structure? Basically, how are you going to measure whether or not the outcomes of this new structure is successful? Thank you.
Thank you for that, and that's probably quite timely, actually. So as I mentioned, we're doing the launch on Monday, so we are working with all the new leadership roles, and the company that we've got doing the organisational development with us are helping to facilitate a workshop on Monday that will look at what those success criteria are. So we are looking at a number of different stakeholders and asking them to think about what does success look like, and how are we going to build those success criteria, and how we're going to measure them. So I think it might be timely for the next meeting for us to share what we think those success criteria are. And we'd be more than happy if you wanted to provide us any feedback on that, and we can add to some of those success criteria.
Yes, I think Susan, Councillor Susan Smith would be happy with that. So yes, and thanks for the question, Mary. Yes, Colin.
Thank you, Chair. I think you touched on this at the very end, Claire, but I think some kind of diagrammatic presentation, as it were, would be helpful for us to actually understand this more clearly, as it were, because clearly it would appear that obviously all the roles interrelate in one way or another, and cross-referencing in different ways, but it's not always apparent from this sort of written list, as it were. The other thing I wondered is to what extent it might, for example, have required rewriting job descriptions, person specs, etc. Given that there's been an application for jobs, presumably largely internally, as it were, but nevertheless, a restructuring would involve a lot of this rewriting, as it were. So I just wonder to what extent that may have changed some of the roles, or whether roles have been merged to a degree in order to, if you like, accommodate the need to achieve efficiencies and so forth.
Yeah, so I guess first of all on the structure, because we're launching it on Monday, the structures will be attached to that, so we will make sure that you get a copy of the structure. In terms of the job descriptions and the people who've been appointed into the posts, a lot of the preparation work was thankfully done before COVID hit, because we were going to launch last May. So there has been some new job descriptions that we've pulled together. And the other thing is we went through a consultation period with the staff that we had already in the organisation, and there were some staff that slotted in, and there were other staff that had the opportunity to apply for other jobs. But we've also got some people that have come from outside the organisation who applied for and got the jobs through the competitive interview process. But yes, there have been a number of new job descriptions and changing of some of the differences of the job descriptions to make sure that it fitted with this new model. And obviously, other areas, as I've said, had job descriptions. So we were able to look at some of those job descriptions and use some of the frameworks that they'd got to support the job descriptions that we've implemented. But we did go through a rigorous recruitment process, which included patients and carers and people with lived experience, as well as a number of different stakeholders as part of that process.
Thank you.
Okay, John. You've got a few actions, I think, Claire, haven't you, to provide? But I'd like to see a structure.
That's
I think
fine.
It's a very good idea. Yeah. Okay. Any other questions, anybody? No? All right. Well, as far as I can see, that's the end of the meeting, apart from the date of the next meeting. So do we decide that now, Peter, or when? And when about should it be? How long a gap do we have?
Sorry, apologise for that. I was on mute. We're looking for a meeting in March, I would suggest.
Right. Okay.
Maybe
Anybody
Thursday the 11th or the 18th. I don't know if that's is this time 10 o'clock. Is it a good time for members? This
it's a good time for me. 11th or the 18th. Anybody got a preference? I'll give one 11th.
How does it fit in with the budget process, Chair?
No idea.
The trust budget process.
She's gone. Well, it's in March, so I don't know. But you want that report, don't you? How they're going on. Or shall we say the 18th then, just in case? Give them a bit more time.
Okay. Yeah. 18th,
10 o'clock on the 18th. Is that all right?
We'll probably be on Zoom again, I'm afraid. But,
Oh no, I hope not. No, I'm sick of Zoom.
I suspect it will.
Yeah, I suspect we will as well. Never mind. Anyway, it's been. Anybody got any questions about anything to do with this? No. Well, thank you very much. She's gone now, but Andrea and also Claire for your very lucid presentations. And as Colin said, will you please make sure all the staff know how much we appreciate what they've been doing?
We will do, and thank you for that.
Okay. Anybody? Can we go now, or back to having a nice cup of tea in the next meeting?